PharmaPal.
You're listening to Bloomscast, the official podcast of Blooms.io, home of the bioactive library for mass spectrometry instant optimization. Let's dive into the latest in natural chemistry, bioactive discovery, and the future of lab innovation.
Okay, so myrrh. It's not exactly a new kid on the block, is it?
Oh, definitely not. It has this incredibly long history in traditional medicine, across loads of cultures, really.
Right, used for all sorts.
Yeah, the sources mention it for, well, a wide variety of things. But what's really relevant for us today is that ancient traditional Persian manuscripts actually talk about it as a potential uterine stimulant.
Wow, even back then. Suggesting it for, abortion?
The potential was noted, yeah. So the idea isn't new at all. It shows, these deep historical roots for this specific kind of use.
That's fascinating. And there's that specific name in Persian medicine you mentioned.
Exactly, yeah. Myrrh-e-maki. That's the true myrrh, the one from the Commiphora myrrh tree.
Myrrh-e-maki.
Mm-hmm. And it's not just a label. It really points to how significant it was, and, still is culturally in places like Iran. Herbal remedies are a huge part of healthcare there.
And it's even mentioned in the Encyclopedia of Islamic Herbal Medicine.
It is, yeah, which just reinforces that historical and cultural importance.
Okay. And there was also that brief mention about childbirth, something about royalty.
Yeah, kind of a side note, but interesting nonetheless. Myrrh oil, apparently used during childbirth, maybe to ease labor pains.
But maybe just for the elite, it sounds like.
Seems that way, yeah. Described as an older practice associated with royalty. But it just underlines again that myrrh has been linked to women's health for a very, very long time.
Okay, a really deep history then.
Mm-hmm.
So to understand why it's being studied now, specifically for incomplete abortion, we probably need to clarify what that term actually means.
Right, so essentially an incomplete abortion is when a pregnancy ends. But, well, some of the tissue, the products of conception, get left behind.
Tissue-like.
Could be fetal tissue, placental tissue, or membranes. Some of it remains inside the uterus after most has been expelled.
Okay. And that's a significant issue, medically speaking.
Oh, absolutely. It's a major global health concern. A big factor, unfortunately, in maternal mortality and illness, especially in developing countries.
So how does modern medicine typically deal with this? What are the standard approaches?
Well, conventionally, there are sort of three main paths. Mm-hmm. First, you've got surgical options procedures like D&C dilation and curettage, or maybe MVA, manual vacuum aspiration.
Okay, the surgical route.
Then there's medication.
Yeah.
Usually prostaglandin drugs. Misoprostol is a commonly used one.
Right.
And the third approach is what's called expectant management, which basically means carefully watching and waiting to see if the remaining tissue passes naturally on its own.
And I'm guessing each of those comes with its own set of, challenges or downsides?
Precisely.
Yeah.
Surgery is invasive, so it always carries risks, right?
Sure.
Bleeding hemorrhage is a particular concern if there's increased blood flow to that retained tissue.
Mm-hmm.
The medication, misoprostol, can have various side effects, and it might not be the right choice for everyone.
Okay.
You're just waiting. Well, that brings uncertainty. You don't know if or when it will pass, and there's always that background risk of complications, like infection, during the wait.
Right, that makes sense. And that uncertainty, those risks, that really sets the stage for why researchers might explore alternatives, like myrrh.
Exactly.
Which brings us squarely to that clinical study. What was the core question they were trying to answer?
Yeah, the fundamental objective was twofold, really. Is myrrh effective in helping the body clear out that retained tissue after an incomplete abortion? And crucially, is it safe to use in this specific situation?
Okay, effectiveness and safety. How did they set up the study to find out?
They used a very rigorous design, a randomized, double-blind, placebo-controlled clinical trial, which is generally seen as, a strong way to test something.
Right, the gold standard.
Mm-hmm. They recruited 80 women who all had ultrasound confirmation of having retained products of conception RPOC.
Okay, 80 women with confirmed RPOC.
And these women were randomly assigned to one of two groups. One group received 500 milligram capsules of myrrh.
How often?
3 times a day for 2 weeks. The other group got identical-looking placebo capsules, just filled with cornstarch.
And double-blind means?
Means neither the participants nor the researchers administering the treatment knew who was getting the actual myrrh and who was getting the placebo.
Ah, right, to prevent bias creeping in.
Exactly. Helps ensure the results are more objective.
So, after the 2 weeks, they checked again with ultrasounds. What did those show?
Well, the results were quite significant. They found a notably greater reduction in the average size, the diameter, of the retained tissue in the women who took myrrh compared to those who took the placebo.
Okay, a measurable difference in size.
Yes. And perhaps even more importantly, the rate of successful complete abortion, meaning the uterus was fully cleared, was significantly higher in the myrrh group.
How much higher?
It was about 82.9% in the myrrh group compared to 54.3% in the placebo group.
Wow, that's a big difference.
It really is. And that difference was statistically significant, meaning it's unlikely to be just a random fluke. It strongly suggests the myrrh was having a real effect.
That's compelling on the efficacy front. What about safety? Any issues reported?
That was another positive finding from the study. They reported no serious drug-related adverse effects in either the myrrh group or the placebo group.
So for this specific use, treating incomplete abortion, it appeared to be well tolerated in this trial.
It seems so, yes, based on this data.
So given these results, what did the study authors conclude?
They concluded that myrrh appears to be both effective and safe for resolving retained products of conception after an incomplete abortion.
Suggesting it could be an alternative treatment option?
Potentially, yes.
Yeah.
But they were also careful to emphasize that, more research is definitely needed. We need to figure out exactly which active compounds within myrrh are responsible for the effects.
Right.
And get a much better grip on precisely how they work in the body.
Did they have any initial theories on the how? You mentioned uterine stimulant earlier.
They did. The main hypothesis is that the resin component of myrrh acts as a uterine stimulant.
Okay. Makes the uterus contract more.
That's the idea. They proposed a few potential mechanisms. One thought is it might help open certain calcium channels, voltage-gated ones, in the uterine muscle cells, and calcium is key for muscle contraction. Another possibility is that it inhibits the production of nitric oxide, which is a molecule that can relax uterine muscle, so inhibiting it might promote contraction.
Okay, multiple angles.
And they also floated the idea that it might stimulate the production of prostaglandins, which are well-known triggers for uterine contractions. So several ways it might encourage the uterus to contract more effectively.
Interesting. And wasn't there another potential plus side mentioned, something related to infection risk?
Yes, good point. When tissue stays in the uterus, there's an increased risk of infection, specifically endometritis, an infection of the uterine lining.
Right.
The researchers noted that none of the women in the myrrh group actually developed endometritis during the study.
Oh, that's interesting.
Yeah, so they theorized that maybe myrrh's known antimicrobial properties could be playing a role in preventing that complication too. An added benefit, perhaps.
Okay, so multiple potential mechanisms at play. Let's zoom in on myrrh itself for a second. What is it actually made of? What are its main components?
Chemically, it's quite complex, but it's primarily a mixture of volatile oil, resin, and gum.
Oil, resin, gum. Okay.
And within these parts, there are various bioactive compounds. For instance, compounds called furanosesquiterpenes.
Foreign. Say it again?
Furanosesquiterpenes. Bit of a mouthful. They're thought to give myrrh its characteristic smell, but also might contribute to its analgesic effects, its pain-relieving properties.
Okay, pain relief too.
And beyond that, other studies have indicated myrrh possesses a whole range of other properties. It's shown anti-proliferative activity.
Meaning it stops cells growing?
Yeah, inhibits cell growth, also antioxidant, anti-inflammatory, and as we mentioned, antimicrobial effects. So it's doing quite a lot biologically.
Seems like it. And the study mentioned it's been looked at for other conditions too, not just in gynecology.
That's right. There have been clinical studies investigating its effectiveness for things like schistosomiasis, that's a parasitic disease.
Right.
Also for recurrent athostomatitis, which are common mouth ulcers, and for trichomoniasis vaginalis, an STI.
Wow, quite varied.
Indeed. And there are also some in vitro studies, lab-based studies, so very early stage research, that have suggested it might have potential against certain gynecologic cancers and even prostate cancer, but that's very preliminary.
Okay, so clearly a substance with diverse biological actions, but now we need to turn to the other source, the case report, the one flagging potential risks. What did that describe?
Yes, and this provides a really crucial contrasting perspective. This report detailed the case of a 32-year-old woman in Saudi Arabia. She was pregnant and had a history of infertility and also recurrent miscarriages.
Okay, a difficult background.
Yes, and based on advice from a traditional healer, she started taking large amounts of myrrh every day for about 2 months. The hope, presumably, was that it would help her maintain this pregnancy.
But that's not what happened.
No, unfortunately not. At 9 weeks into the pregnancy, she presented to the emergency room with severe acute abdominal pain.
Oh, dear.
Initially, she didn't tell the doctors about taking any herbal remedies, but later she admitted she'd been consuming a significant quantity of myrrh daily.
And what happened with the pain?
Importantly, her symptoms resolved relatively quickly after she stopped taking the myrrh.
So the timing strongly pointed to the myrrh being the culprit.
That was the strong assumption of the report's authors, yes. They believed the myrrh acted as a uterine stimulant, but this time, crucially, in an ongoing, viable pregnancy. And that stimulation directly caused the acute pain she experienced.
Which must have led them to issue a serious warning.
A very strong one. The authors explicitly cautioned against the oral intake of myrrh during pregnancy.
Because of that stimulant effect.
Precisely. Because of its potential to stimulate the uterus, which could, they warned, lead to serious complications like miscarriage or preterm labor.
Okay. Any other warnings? Dosage.
Yes, they also pointed out that high doses, they suggested maybe greater than 2 to 4 grams per day, might cause other issues, like kidney irritation or changes in heart rate. And a key problem, there's no scientifically established appropriate or safe dose range for myrrh.
That's a major gap. And wasn't there also a mention of an interaction with a common medication?
That's correct. The report highlighted a potential interaction with warfarin, the anticoagulant or blood-thinning drug.
What kind of interaction?
That myrrh might decrease warfarin's effectiveness, which of course could increase the risk of blood clotting.
That's a significant risk for anyone on warfarin.
Absolutely, a very important consideration.
Okay, so we have this clinical study suggesting myrrh could be beneficial and safe in the specific context of incomplete abortion.
Helping clear things out after a miscarriage has occurred.
Right. And then we have this stark case report warning it's dangerous during an ongoing pregnancy. How do we reconcile these? How do we understand this nuance?
I think the absolute crucial factor here is context, specifically the state of the pregnancy. Are we talking about tissue that needs to be expelled after a pregnancy has ended, or are we talking about an ongoing, developing pregnancy?
So the timing and the situation are everything.
They're critical. The clinical study was focused on women who had already, unfortunately, experienced a miscarriage and had retained tissue. In that scenario, encouraging the uterus to contract and expel the tissue could be seen as therapeutic.
Completing the process naturally, maybe?
Perhaps, but the case report involved a woman with a viable pregnancy. In that context, stimulating uterine contractions is generally contraindicated and potentially very harmful.
So the very property that might be helpful in one situation is dangerous in another.
Exactly. That uterine stimulant effect is the key double-edged sword here.
Right.
Which means both of these sources, looked at together, really hammer home the need for extreme caution, and they both highlight the need for much more rigorous research.
Which one specifically?
We need better understanding of dosages, we need to identify the specific active compounds doing the work, and really pin down their mechanisms. And we need to remember the limitations the authors themselves noted in the clinical study, small sample size. The dose was chosen somewhat empirically.
Right, not based on extensive prior data.
Exactly. We still lack that definitive understanding of exactly what component causes the uterine stimulation and how potent it is.
Okay, so let's try and summarize then, bring our deep dive to a conclusion. What are the absolute key takeaways for you regarding myrrh, incomplete abortion, and pregnancy?
I think there are two main, potentially conflicting but context-dependent takeaways. First, the clinical study suggests myrrh might be a promising, effective, and possibly safe treatment for incomplete abortion. Helping the body expel retained tissue after a miscarriage is already underway.
Okay, potential benefit in that specific post-miscarriage scenario.
Yes, but QEDS-T, and it's very significant, but the case report serves as a vital warning. Using myrrh during an ongoing viable pregnancy appears to carry substantial risks.
Because of that uterine stimulant effect.
Exactly, potentially leading to pain and increasing the risk of miscarriage or preterm labor. So, context is absolutely king here.
That's a really critical distinction to grasp. It definitely highlights the complexities when we examine traditional medicines with modern scientific tools. So perhaps a final thought for you, our listener, to consider. Given myrrh's incredibly long history, alongside this emerging, sometimes conflicting scientific interest, how can we best move forward? How can we responsibly explore any potential benefits while ensuring patient safety above all else, and also respecting the traditional knowledge systems where this originated? And maybe what specific research questions do you think are most crucial now to clarify Myrrh's role or lack thereof in different aspects of reproductive health?
Yeah, really important questions. It's clear there's still quite a journey ahead to fully understand this ancient remedy in a modern context.
Thanks for tuning in to Bloom's Cast, brought to you by Blooms.io. Stay curious, stay connected, and we'll see you next time on the frontier of natural product innovation.
PharmaPal.